Okay, first of all, I want to thank the organizer for inviting me. I get the difficult part as the coordinator of the precision medicine platform in our university. However, I think it's much fun also to give some arguments against NGS testing for every patient outside of clinical trials. These are my financial disclosures. As I mentioned, not every argument I'm using now necessarily represent my personal opinion. So I'm not going to talk about actionable targets like HER2 in gastric or RAS in metastatic colorectal cancer. I think it's standard, we don't have to talk about this. However, my talk is somehow divided into immunotherapy and the classical targeted treatment, and I want to talk about actionable biomarkers in immunotherapy we are using for GI cancer first. So we all use PD-L1 expression status in stratifying patients or outside of clinical trials also to predict potential benefit out of IO treatment in patients, especially in the upper GI tract, as well as, of course, the mismatch repair deficiency, which is a reliable and reproducible marker for IO therapies. However, I give you a good example like the KEYNOTE-059 study, which was fully published last year in Lancet Oncology. And this is very nicely showing that there are patients who are PD-L1 negative who also have a benefit of a treatment with Pembrolizumab in this late-line setting. This is clearly demonstrating that 1/3 of all PD-L1 negative patients had a reduction in the tumor load when treated with this immunomonotherapy in this pre-treated setting. Another good example was given today by Joseph Tabanero in his nice presentation of the KEYNOTE-062 study. In this study, notably, patients were not pre-treated with chemotherapy. It's a first-line study, and all patients had tumors which were considered as PD-L1 positive with a CPS score 1 or higher. One aim of the study was to compare classical chemotherapy alone versus chemotherapy plus Pembrolizumab. And as you all know, this study and this two comparison was negative. There was no benefit by adding Pembrolizumab to the chemotherapy. But notably, in this subgroup of the high CPS score patients, CPS 10 plus, you can see that probably PD-L1 is not the right biomarker, as we know that there were a subgroup of patients with higher response rates when you compare it with classical chemotherapy alone. So we have to do it better to search for other predictive marker in immunotherapy, and there might be then a better definition of this group of patients who have a benefit from immunotherapy. We all have heard and know also here in Europe that FDA grants accelerated approval to Pembrolizumab for tissue, a tumor agnostic indication based on microsatellite instability. So this is US, this is not Europe or not all of Europe. So in Europe it's not approved yet. However, it's still many questions open. So, for instance, this is the example of the CheckMate 142 trial, nivolumab plus low-dose ipilimumab combination in MSI-high colorectal cancer patient in first line. So we have seen this data presented by Heinz-Joseph Lenz last year at ESMO with very convincing response rates in this chemotherapy-free treatment in this MSI-high patient's first line. We did see a response rate in this patient population of 58%, disease control rate of 78%. So this is quite convincing. However, we can expect this also for chemotherapy in first-line treatment, although not in the MSI-high selected population. So doublet chemotherapy plus bevacizumab resulted in the FIRE3 trial, 59% response rate. With cetuximab, 65% response rate, and in the triplet chemotherapy plus bevacizumab, 61%, and plus panitumumab, 87% response rate. Okay, this is a crossover comparison. This is not really allowed. We have to wait prospective randomized trials in the MSI-high patients, and we are expecting the data, for instance, from the KEYNOTE 177 trial, which might then guide us towards a first-line chemotherapy-free treatment, yes or no. So in summary, for IO treatment in GI cancer, I conclude that PD-L1 is a weak and probably or likely the wrong biomarker to predict the treatment response upon the immunotherapy. We have seen PD-L1 negative patients who might benefit from IOs. On the other hand, not every patient PD-L1 expressing tumor do have a benefit from immunotherapy. In the lower GI tract, PD-L1 expression is useless. For mismatch repair deficiency, we know this is a reliable and reproducible biomarker which predicts a clinical benefit from IOs in colorectal cancer. However, in the upper GI tract, we see patients with proficient mismatch repair, and those patients might also have a benefit from IO. So let's talk about the classical targeted treatment. I give you some examples of actionable targets. One was nicely presented by Talia yesterday, and this is really very stimulating data from the POLO-Trial in the BRCA-Mutated metastatic pancreatic cancer setting, where Olaparib was used as a kind of maintenance strategy. However, and we discussed it already in this session, this could not be translated into an overall survival benefit yet, which is somehow, let's say, notable. So for me, BRCA testing at the moment in pancreatic cancer can assist clinicians in genetic counseling. However, there are many open questions. Does Olaparib also work in BRCA wild-type patients, for instance, like in ovarian cancer? Do we really need to test now for BRCA if overall survival is not improved? I'll give you another example. Let's go to colorectal cancer. BRAF mutation, we know, is a driver mutation. It really drives the tumor biology, makes the tumor more aggressive, and we know that BRAF is prognostic. However, its predictive role is uncertain. If you look on the triple chemotherapy, like this prospective clinical phase II trial, which was a randomized trial, triplet chemotherapy versus doublet chemotherapy plus panitumumab in both arms, you clearly can see, although low patients number, that BRAF mutated tumors seems to do the same like the ITT population. So it seems that BRAF mutation seems not to predict treatment response. Quite similar results were seen in the TRIBE trial, triplet chemotherapy plus bevacizumab with big standard deviation, low patients number, only 28 patients. But also in this, I would not conclude that BRAF predict the response towards the treatment. We will see the data from the Beacon trial on Saturday morning, and we know from the press release that this is a positive trial. So patients with BRAF V600E mutation after failure of first-line chemotherapy were liable to be treated with a MEK BRAF inhibitor plus cetuximab or cetuximab plus BRAF inhibitor in the third arm, classical chemotherapy plus cetuximab. We know from the safety lead-in phase that their response is likely when we treat chemotherapy-free with cetuximab, BRAF, and MEK inhibitor, and the press release was also positive. This led to FDA granting a novel triplet breakthrough designation for this patient. However, not in Europe. It's not approved by EMA, and most likely also not on Monday when you go back into clinic and see the next patient. Let's shortly talk about HER2 and metastatic colorectal cancer. We have seen more and more data that this seems to be somehow kind of resistant mechanism in the RAS wild-type patients when they were treated with an anti-EGF receptor inhibitor, and you could or you might overcome this resistance by targeting this HER2 by, as it was used here in the Heracles trial, trastuzumab plus lapatinib. This trial really did show a very convincing response and durable response in these patients with tumors overexpressing HER2. These data were presented at ESMO in 2015. Remember the year, okay, 2015. However, we have guidelines here in Europe, the ESMO guidelines, which were published 1 year later, 2016, and they were addressing the emerging biomarkers. ESMO is saying BRAF mutation status should be assessed for prognostic value. MSI testing should be assessed to guide clinicians for genetic counseling, and they were already mentioned in 2016 that MSI testing has strong predictive value for the use of immune checkpoint inhibitors, and they were mentioning Pembrolizumab. However, evaluation of HER2 amplification or HER2 activating mutations is currently not recommended outside of clinical research. Evaluation of HER3 and MET receptor overexpression, not recommended. Detection of mutation in PIK3CA, so exon 20, is optional. Loss of PTEN is not recommended. Evaluation of EGF receptor ligands, amphiregulin, epiregulin, and others, not recommended. And evaluation of EGF receptor expression, not recommended by ESMO. So we know from NCCN, and this was published in 2015 in the Journal of National Comprehensive Cancer Network, in a retrospective analysis, that patient, here 677 patient adherence or non-adherence to guidelines for colorectal cancer, those who were treated non-adherent to guidelines, they have an almost fourfold increase in risk of death within 1 year, and still in the year 2 to 5, an almost twofold increased risk of death. So my conclusion is, outside of a clinical trial, NGS testing for every patient is not there yet, but within a clinical trial, go ahead. We're doing it. We know MD Anderson is a leading institution for doing it, but if you go to your clinic on Monday, probably do not have to test every patient with an NGS panel yet, because actionable targets are rare and not every targeted therapy is approved yet. Thank you very much for your attention.